Hello, everyone. On webinar online, especially ICU doctors and nurse and ICU practitioner. Good night. Today my name is Wang Xiaoting. Today I'm one of the 3 moderators. It's my honor. So in the past months, we hold a series of course about diagnosis and treatment of the sickest patients of COVID-19 patients, especially COVID-19 patients get severe and got worse and worse. They need to receive the ICU support, ICU therapy, ICU treatment. So tonight we have three moderators. One is Professor Cao. It's my pleasure to introduce himself. Hi, Dr. Cao.
Hi, hello. Thank you, Xiaoting. Hello, everyone. I'm Dr. Yengong Cao. I'm a director of Department of Critical Medicine in Tsinghua University First Hospital in Beijing. And it's my pleasure to be here to be a moderator. I think, as we all know, there's more than 10% COVID-19 patients will become very severe. And as Professor Xiaoting mentioned, these patients need intensive care, such as monitor oxygen therapy, and also mechanically ventilation, and so on. And some of these kind of patients will have to treat it with ECMO because of very severe respiratory failure. So I think we try to invite our colleagues to introduce this kind of information to all of you, to maybe have a little bit of help to give you. I think it's my ideas and my honor. Thank you.
Mm-hmm. Hi, thank you. Maybe I have some introduce about me supplement. Just now I say my name is Wang Xiaoting. I come from China, come from Beijing. I worked Peking Uni Medical College Hospital. I'm an ICU doctor. I'm the co-chair of Chinese Critical Ultrasonography Study Group. I think what the Professor Cao mentioned, he is co-chair of the Chinese Critical Ultrasound Study Group. Hi, it's my pleasure to introduce another moderator tonight, Professor Zhu Ran. Hi.
Hi, Xiaoting. Let me introduce myself. Good evening, dear colleague. My name is Zhu Ran. I work in Department of Critical Care Medicine and ICU attending. I work in the first affiliated hospital of China Medical University. I'm also vice chair of CCUSD. I have been combating with COVID-19 until late March. I gave the first speech of this webinar series with the topic of respiratory management with critical ultrasound for COVID-19 patients on March. And I will be glad to answer any questions from the audience within my capability. Thank you.
Okay, thank you. As we all know, COVID-19 patients got a severe respiratory failure, and respiratory failure always need oxygen therapy, just like common oxygen therapy, and the mask and the nose and high flow nasal oxygen, and the mechanical ventilation, and in the sickest patients of the COVID-19 got with respiratory failure. Maybe these patients require ECMO treatment. So today we recommend an important theme about the critical ultrasound and ECMO, how to use. critical ultrasound to help the ECMO perspectives. So it's my honor to invite tonight the important Professor Tsai Su-han to take a lecture. So let's begin.
Hello, everyone online. Best wishes to every doctors and nurses who are taking care of COVID-19 patients. I am Dr. Tsai from Department of Critical Care Medicine, Zhongnan Hospital, Wuhan University. And I just finished the medical works in Leishenshan Hospital as a medical supervisor of one of the ICU wards, which some critical ill COVID-19 patients were treated. I am honored to have this opportunity to talk about critical ultrasound integrated ECMO management in COVID-19 patients. Although we are going to talk about ECMO in COVID-19, we need to know why and how should we do the respiratory support for the respiratory failure patients. It is not just support, but also protection for the patients, which is even more significant. COVID-19 patients do not only have respiratory failure, but also circulatory problems, especially acute campanile, which is a common severe circulatory problem in the severe patients that maybe need to deal with ECMO in the most severe ones. And then we will talk about the significance of ECMO and critical ultrasound integrated ECMO management in COVID-19 patients. From the early phase of the pathology of these two cases, which were taken from operations because of cancer, we can see that the virus only invades the epithelial cell and make an exudate, which can make poor oxygen diffusion. A 50-year-old man was admitted to a fever clinic on January 21st, 2020, and confirmed the PCR-assay that the patient had COVID-19 on the second day. This is the autopsy pathology of this patient. This patient accepted therapy in the hospital and died 6 days later. The autopsy tells us the lungs are turned to be edema and hyaline membrane inflammation. He had a light injury in liver and no significant injury in heart. Another patient's pathology of biopsy shows worse lung injury. This patient accepted longer and much more respiratory support therapy and didn't survive from lung transplant. This patient was the first lung transplant in Shenzhen of China. The last patient is much older than the patients before, had some chronic diseases and was treated 28 days. The autopsy shows that the lungs injury is severe and has white foam mucus in the trachea. And there is also something wrong in the heart, small intestinal, spleen, liver, kidney, and other organs. According to the autopsies and biopsies above, National Health Commission of the People's Republic of China told us that the critical ill COVID-19 patients would turn to be MODS at the late phase of the disease, beside of respiratory failure. So we can see the often seen clinical manifestations of critical ill COVID-19 patients is that continuous aggravation of pulmonary injury after virus infiltration, triggering primary condition of respiratory failure and secondary conditions of clinical circulation changes and multi-organ injury. However, the MODS is because of SARS-CoV-2's invasion or for other reasons. Let's talk about this from the relationship of COVID-19 and ARDS. As we all know, the alveolar epithelium and vascular endothelial cells are both injured at the early phase of ARDS and gets the edema worse and worse. If a critical ill COVID-19 patient couldn't get any treatment, virus invasion into the epithelial cells will cause alveolar collapse and interstitial infiltration. When the lesion is large enough, pulmonary ventilation, oxygen diffusion, and VQ ratio mismatch will lead to hypoxemia. Respiratory drive will be enhanced for compensation of hypoxia because of hypoxemia and lung compliance reduction, which cause further lung injury. Decompensation of hypoxia and CO2 retention will cause death. There are some sudden deaths because of acute compartmental, which is also called ACP, at the early phase of COVID-19. This picture can illustrate the vicious cycle of injury present in patients with acute respiratory failure. Patient self-inflicted lung injury is due to the increase of transpulmonary pressure and transvascular pressure, which will lead to endothelial cells injury and worsening the exudate. Even in the natural cause of COVID-19, the lung injury can be caused by virus infection, which is primary injury, and the compensation-induced injury, which is secondary injury. We can see the primary injury can lead to low PF ratio, fast respiratory rate, and large area of lesion in imaging tests such as CT. We also should know that strong respiratory drive will lead to the secondary lung injury. The VQ ratio mismatch and high oxygen consumption will lead to hypoxia and the other organ dysfunction. So we can see that the primary lung injury of virus cause just a type 1 respiratory failure, which is just a diffusion dysfunction of oxygen, while the secondary injury will get the lungs turned into classic ARDS, including lung volume reduction, lung compliance reduction, the VQ ratio mismatch. As the phase of the disease goes on, the lungs will change from exudate period to fibroblast and turned out to be fibrocysts at last. Now, let us see the treatment method for the severe COVID-19 patients. As far as we know, there is no specific antivirus drugs to be efficiency to COVID-19. So the main treatment is support therapy. such as oxygen therapy, taking rest, diet, sleep, temperature management, etc. For the critical ill COVID-19 patients, we need to do the organ protection and life support and prevent subsequent infection until the autoimmune system clear the virus. But the support therapy, such as mechanical ventilation, also has subsequent injury, just like a double-edged sword. For the primary virus injury, we know the epithelial injury and the exudate and the increase of pulmonary vascular resistance. For the secondary compensatory injury, we know the increase of respiratory drive and the sympathetic over activation. For the therapeutic injury, there may be inappropriate fluid management, ventilation-associated injury, including lungs and heart, subsequent infection and compliance of life support, such as the catheterization, CRRT, and ECMO, etc. In all the respiratory support therapies, the normal common oxygen therapy and HFNC can improve hypoxia for the moderate patients, but most of people need ventilation. NIV and MV both can enhance the risk of mechanical injury to lungs and pulmonary vessels, while ECMO can make the lungs have a rest. Although high PEEP strategy was recommended by the ARDS guideline, we found that PEEP might be harmful to the lungs of COVID-19 and ARDS patients. You can see the compliance would turn to be worse as increasing the PEEP, because high PEEP cannot get more collapsed alveoli open, but make the normal alveoli overinflated. When the lungs get hurt, the heart gets hurt. So we will talk about main mechanisms of cardiac injury in COVID-19 patients, ACP. These are the definition of ACP from different articles. Copamnel is a form of right ventricular dysfunction due to an acute increase in RV afterload. It also refers to acute dilation or dysfunction of the right ventricle in the context of acute lung diseases such as ARDS and associated pulmonary vascular dysfunction. ARDS patients have the risk of ACP because ARDS patients' right ventricular afterload will increase. 14 to 50% ventilation ARDS patients have ACP with the average is 25. There are 4 risk factors of ACP. If the ARDS is caused by pneumonia, if the PF ratio is less than 150, or the PaCO2 is more than 48, and if the driving pressure is more than 18, are the risk factors of ACP. This picture shows the mechanisms from ARDS to ACP. The ARDS with microthromby and hypoxemia, hypercapnia edema, and the overdistension or loss of lungs volume. The 6 factors will increase the PAP and get the ACP performed. Especially for the COVID-19 and ARDS patients, the hypoxemia, hypercapnia, edema, and the increased regional FRC or decreased regional FRC all exist, and some ARDS patients also have microthrombi. When the lung capacity is functional residual capacity, the pulmonary vessels resistance is the lowest. If the lungs volume is small, the alveolar collapse, the PVR will be high, and if the lung volume is too high, the pulmonary alveolar volume, the capillary diameters will reduce and also makes the PVR high. So we should get if we make MV for the ARDS patients, we should get the lung volume as near as the FRC. Maybe someone want to do the RM or use the PEEP to balance the volume of the lung, but you can't do it. It's just like trying to sacrifice a part of normal fighting force and risking calling some wounded to join the battle of hurting friendly forces. The normal fighting force is the normal lungs, and the wounded is some lungs already injured. If you do the RM, it might not be opened, but you can make the PVR high and hurt the friendly force, which is RV. Because of the right ventricular characters of anatomical features, it is the ventricular wall is very thin and crescent shaped, and its main function is to optimize the systematic circulation, keep low RA pressure, and keep low resistance of pulmonary circulation. The differences between left and right ventricle is very clear. The left ventricle can tolerate sudden increased afterload, while the right ventricular cannot tolerate the sudden increase of afterload, but it can tolerate the sudden increase of preload. This picture can show us that when the left atrium pressure is increased from 10 to 20 centimeter H2O, the stroke work increased rapidly. But the right ventricular, for the right ventricular, when the RA pressure increased from 220, the stroke work hardly changed. Also, for the afterload increase, if the MPAP increased from 20 to 30, the right ventricular stroke volume will reduce. But for the left ventricular, even if the MAP increased from 100 to 140, the stroke volume of LV hardly changed. And also there is a mechanism about the interaction between the two ventriculars. The main anatomy factors is the septum, pericardium to limit the two volumes of the volumes of the two ventriculars, and the association between the cardiac muscle fibers. It's about approximately 40% of the right ventricular constriction derived from airway constriction. When the afterload of the right ventricular increase seriously, dilated right ventricular will make the septum flattened and compress the left ventricular. Left ventricular stroke volume will reduce clearly. This is the ultrasound diagnosis of ALI-induced ACP. The diagnosis standard, the first one is the right ventricular dilatation. When the ratio between right and left ventricular and diastolic areas is more than 0.6, it has ACP. If the ratio is more than 1, it's severe. It's a severe ACP. The second standard diagnosis standard of ACP is about the abnormal motion of ventricular septum. You can see the diastolic or systolic abnormal motion of ventricular septum, even it get to the D shape. This case of APE caused ACP, you can see that the dilated right ventricular and the flattened septum and the D-shaped left ventricle, and also because of the high pressure of right ventricular, the IVC is the IVC's diameter is large. For the most critical ill COVID-19 and ARDS patients, even the protective ventilation strategy cannot protect and support the patient's life. Then we need ECMO to rescue the patient. ECMO means extracorporeal membrane oxygen. It means that the venous blood of the patient was extracted from the body by centrifugal pump, and oxygen was combined with carbon dioxide removal by the membrane oxygenator and returned to the patient, which can provide long-term cardiopulmonary support and provide opportunities for the recovery of the primary disease or the transition to cardiac auxiliary device or cardiopulmonary transplantation. The significance of ECMO is as a support method for severe respiratory and circulatory failure. ECMO is the last salvation treatment option for COVID-19 patients. Patients with fatal hypoxemia who cannot be improved by the respiratory treatment, such as lung protective ventilation, neuromuscular blockers, prone position, lung recruitment, etc., should receive ECMO support as soon as possible. Next, we'll talk about the ECMO indications and mode selection. The four pictures shows the schematic diagram of ECMO mode. The picture A is VV ECMO. It's simply exemplified the ECMO illustrating draining venous blood from the IVC and returning oxygenated blood to the right heart via the right internal jugular vein. VV ECMO is also amenable to cannulation with the double lumen cannula in the right internal jugular. The picture B is for VA ECMO. It is illustrating the draining venous blood from the IVC and returning oxygenated blood to the aorta for retrograde circulation via the right femoral artery. This is only one example. Cannulation site may be vary, can also by an operation into the aorta. The picture C is VAV ECMO. It involves adding a third cannulation site to address a clinical issue is sufficiently addressed by either VV or VA ECMO. Blood is drained from the IVC and returned to both the arterial system and to provide cardiac support, and the venous system to provide augmented respiratory support. Picture D is a VVA ECMO it used in rare instances. One cannula may not adequately decompress the venous system or may not allow for sufficient flows. A second cannula can be added to improve the venous flow in this pattern. These are the indications and the contra-indications of ECMO. VV ECMO can be initiated for severe hypoxemia together with or without hypercapnia and acidosis. Patients came up with acute circulatory failure, which proved to be cardiogenic shock. When this happens, VA ECMO can be considered. The absolute contraindications to VV and VA ECMO include the absolute the progressive and non-recoverable diseases that not suitable for the transplantation, or severe neurology injury, or intracerebral bleeding, and some other special reasons, contraindications to VA and VV or VV ECMO. As we know, ECMO also might cause some severe complications. ECMO may not provide an opportunity for severely damaged organs to recover, while the risk of these complications will be high. In order to reduce the complications of puncture, we use ultrasound to help us. These are the pictures when we did ECMO in Zhongnan Hospital and Leishenshan Hospital. We have already got 14 patients received ECMO support in Zhongnan Hospital of Wuhan University. 4 of them survived and already back home, get back home, and 2 patients are still in ICU after weaning of ECMO. 1 patient is still on ECMO support, and 7 have been died. We also have some protocol to help us do the right respiratory support at the right time. including ECMO. The principles of life support should be the oxygen support first, and when we do the oxygen support, we should also do the organ support and do no harm to the organs, and also avoid the secondary injuries. This is the different level of the critical ill, the COVID-19 patients, level 1 to level 5. Level 1 maybe just have respiratory failure, and level 2 have plus the hemodynamic disorder. In level 3, the patient may be circulatory failure or shock, and to the level 4 maybe plus the organ dysfunction beside the heart and lungs, and for the level 5 maybe get cardiac arrest to do the CPR, and for the others kind of COVID-19 patients maybe just have pneumonia and have other disease caused the organ dysfunction except heart and lung. So the indications of ECMO for COVID-19 should be level 2 to level 4. Maybe we can't do that as early as level 2, and level 4, some of the level 4 patients maybe is a little bit late. So the level 3 patients were the most phase of the COVID-19 patients get ECMO. VV ECMO has nearly no hemodynamic influence for the patient. So we'll talk about the hemodynamics effects of VA ECMO. The VA ECMO can reduce the preload and afterload of the right ventricular and increase the afterload of left ventricular, especially when the left ventricular is failure. ECMO increase the left ventricular wall tension and is positively correlated with the flow. Since ECMO is closed loop with the same inlet flow as the output, therefore ECMO does not reduce central venous pressure. VA ECMO, this is a VA ECMO decrease the right ventricular afterload for a PE-induced ACP patient. You can see that after the VA ECMO, the right ventricular is smaller and the septum turned to be abnormal. The D shape disappeared. The CP also turned from 26 to 8 milligram Hg. The VA ECMO, when VA ECMO is initiated, the stroke volume of left ventricle will reduce, and the pulse pressure difference turn to be smaller and smaller. You can see it. See that the VTI gets smaller, and the pulse pressure difference get smaller in the pictures. And for VA ECMO also has another problem, which is Harlequin syndrome. The femoral vein, femoral arterial cannulas with partial circulation support blood in the lower body comes from ECMO oxygenated blood, and the blood supply in the upper body comes from the left heart and the ECMO. When the respiratory support is insufficient, the oxygen content of blood ejected from the left heart is low, and which may affect the oxygen supply of the head and coronary arteries. At this time, the oxygen saturation of the left upper limb may approach 100%, while the right upper limb is relatively low. Therefore, it is recommended that VA ECMO patients routinely monitor the oxygen saturation of the right upper limb. These two pictures shows that when the patients has poor lung function, the oxygen content of blood ejected from the left heart is low. The head and right arm will be short of oxygen delivery. Because the core problem of the COVID-19 patients is systemic hypoxia induced by the lung injuries, and the hypoxia and CO2 retention contribute to the ACP, and also decrease ventilator support may decrease pulmonary vessels resistance. The VV ECMO should be the first choice for severe COVID-19 patients. And the VA mode has also risks of Harlequin syndrome. But when the VV ECMO combined the hemodynamic therapy, 5A and 5P, still with oxygen delivery, should consider VA or VAV ECMO. Next, we'll talk about the ultrasound evaluation and ECMO decision. Some articles showed that ultrasound assists in patient selection, guides the insertion and the placement of cannulas, monitoring progress, detects complications, and helps in determining cardiac recovery and the weaning of ECMO support. So another article already said that ultrasound trained physicians should be a part of the ECMO team. Echo has important effect in diagnosis of ARDS induced ACP, and can help detect the hemodynamic situation when ECMO might be initiated to determine use VV or VA ECMO. This is the protocol from other articles to do to decide which kind of ECMO when and which kind of ECMO should be taken for the patients of ARDS patients. These parameters should be evaluated pre-ECMO of the right ventricular, especially the systolic function is most important, I think. These are the parameters should be evaluated pre-ECMO of the left ventricular. And some other conditions we can find the ultrasound evaluation of hemodynamics in the course of Professor Yin Hong, who gave the course several days ago. In the vessel evaluation, the diameter of the vessels can be measured, and we can see if there is thrombosis. So it helps us to choose the right vessels to get the cannula insert. This is the echo-guided catheterization. We can see the line in the vessels clearly to avoid the damage of puncture. TEE and the TTE can both guide the cannular insertion and the optimal cannular position. Also, we can also use the other method like X-ray, But in COVID-19, because we need to protect the all the staffs, and we can't do the X-ray immediately often. So the TEE and the TTE guided the catheterization is very useful for us. This picture shows the right position of the IVC cannula should be at the junction of cava vena and the right atrium. The TEE and the TTE shows the tips of the cannula. The left picture is a 4D TEE, and the right picture is just an IVC, subcostal IVC screen. This picture shows the insufficient depth of the cannula. It should be inserted deeper. And this picture shows the cannula is too deep to the right atrium. And this is a TEE picture. This is also too deep to the tricuspid valve. The tip of the cannula has already been into the right ventricle, to the right ventricular. For the last section, I will talk about the effects of ultrasound during ECMO. Because of the limitation of time, we just talk about the echocardiogram in managing VV ECMO and some little part of VV ECMO. The cardiac parameter during VV ECMO shows that for the ventricles, we need to measure the size and functions, and the atriums of size and volume. Abnormalities please exist. Location of cannular, pericardial effusion, and the IVC diameter or degrees of collapse. We also need to do the echocardiogram in managing VV ECMO to confirm the causes of insufficient flow. It is maybe a collapse of cava vena, or it also may be the change of location of cannula, or because of lack of volume, the cannula's position will move. We can also need to confirming the location of the tips of cannula every duty. The cardiac function assessment is also needed in the managing of VV ECMO. Let's see a VV ECMO case in Leishenshan Hospital last month. It's a 64 years old female. The history is healthy. She just coughed for 2 weeks and dyspnea for 2 days to get into the hospital. They tested the COVID-19 confirmed, and her situation getting worse gradually, and received the NIV for 10 days in the ward, and then was transferred into ICU for further support. When she got into ICU, we intubated and did the MV support with SMV mode. The VT is 400, 90% of FO2, PEEP is 5, and the P-plat is high to 26. The driven pressure we can calculate it to 21. the compliance is 20 milliliters centimeter every centimeter H2O. At this situation of MV, the SpO2 is just 93%. As we observed the patient for several hours, the patient's hypotension occurred after MV. We gave her NEIV onto 40 μg per minute, and the ABP showed just 8850. And as time goes, the patient turned into oligura, and we tested the LAC up to 8.8. Then we give the patient echocardiogram. We can see the ACP occurred. The right ventricular is large. The septum is septum's motion is abnormal, and D shape occurred, and also the area of right ventricular is larger than left. So we chose VV ECMO for the patient. This echo is taken by 10 hours of VV ECMO. You can see the patient's hemodynamic situation turned to be stable. Although the patient had an unstable hemodynamics before, we still chose VV ECMO but not VA ECMO. Why? We'll talk about it later. But the patient just stable for forever. It's about 24 hours later, the ACP was found again as the lungs deteriorating. We can see the lungs collapsed at the back of the heart, and the right ventricular is large again, and D-shape sign occurred, and we can see the tricuspidal valve regulation occurred. And as this situation, we limited the liquid and did the prone position for more than 12 hours a day. We can see the ACP eased again after 4 days, and the VTI of the left ventricle is 19 cm. To measure the stroke volume of left ventricular is about 45 milliliters. So the patient's ACP was eased again. And we did the ECMO prone position several days later, the ECMO weaning at the day of 9th. And the patient have a problem of weaning from the mechanical ventilation. So we take the tracheotomy at the day of 14 after intubation, and the MV weaning gradually. Until yesterday, the patient has been out of the ICU. If the ACP getting worse or the patient gets a left ventricular failure, VA ECMO might be considered. Just this patient didn't do it. If we do the VA ECMO, we need to evaluate all these things, especially the aorta valve opening and the intracardiac flow auto radiography and the intracavital thrombosis is which are most important. Aortic valve closure causes the left ventricular dilation and thrombosis. We must get the right flow to make sure the aortic valve open and give enough oxygen delivery. If we cannot do this, the left ventricular dilation and thrombus will occur. In this situation, the patient need left ventricular drainage or IABP, even impella. This picture shows the left ventricle dilation and thrombosis. So let's have the summary to get the whole lecture closed. First, I want to tell all of you that the advanced life support and super organ protection are both important for the COVID-19 patients. To clarify the indications and initiate ECMO, the critical ultrasound is very significant. We should do the evaluation by critical ultrasound to determine the mode of the strategy. VV ECMO should be superiority for COVID-19 patients, even if the ACP occurs. If we did the VV ECMO, the heart gets failure, especially left heart failure, we can do the VA or VAV ECMO for the patient. To make that decision, the ultrasound is very important. It's very useful. Ultrasound help decrease and diagnose complications because we can use it to guide to do the cannula incision and to detect the complications. We should monitoring right ventricular function with echocardiogram for ACP patients. This can help us to make the right decision. Thank you for all of you online to listen to this lecture. Thank you.
Thanks for Professor Cai Shuhan's excellent presentation. Tonight, he gave us a very important experience about how to use ECMO to treat our COVID-19 patients with very severe respiratory failure. And also use this ECMO as a tool, as our how to say that, the life supporting the machine to support us or treat us patients, our patients, especially the optimized management is very, very important. So use the ultrasound as your tool to make this to visualize is very important also. So he gave us a lot of this kind of experience to introduce some information, some experience, some ideas from this. First of all, he introduced some pathology and the pathophysiology of COVID-19 patients, and also some indications of how to use ECMO, or when should we use this kind of thing to support us patients, our patients. And also we use ultrasound to guide us or directed our treatment, like cannulation, and also to make sure which is the best position of the tip, and also to reduce the wasted blood flow, something like that, and also to make the best balance between the mechanical ventilation and also the ECMO, this kind of machine, and some preload of the circulation management, something like that. So I think this kind of information in this time is very important to help us to understand the COVID-19 patients and how to optimize the treatment of these kind of patients. I think as usual, we always have some times to do some Q&C session. So now let's move to this part. Let me invite Dr. Zhu Ran to in charge of this session. Zhu Ran.
Yeah, okay, thank you, Professor Cao. Thanks for Dr. Tai's excellent speech. And thanks for Professor Chao's summary. Here's come our Q&A session, and I still have the opportunity to host this session. I think we have already got lots of questions just like before. Since we have almost half an hour left for discussion, I will pick up some meaningful questions, read it, and ask one of my colleagues to answer it. But you can see we have only 3 colleagues here tonight, and we will share all these questions. So now let's begin with the first question. This question is about the hospital-acquired infection. How to deal with secondary infections during ECMO? So I think it's an ECMO topic, so I will ask Dr. Tsai to answer it, please.
Okay, thank you. This is a very good question, and we all take very care about it. The hospital-acquired infection, we must focus on it. The secondary infection prevention, I think, is the most important. When we're doing the ECMO, aseptic technique and hand hygiene should be a routine for every doctors and nurses who are taking care of the patients. For example, the catheter-related infections, especially for the CRBSI, VAP, and urine infections, should be routinely evaluated, and we should remove the catheters as soon as possible once the catheter is not needed. And if infection is suspected, we should do blood routine, PCT, and cultures from the infection location, and the blood should be all should be tested as soon as possible. And we need to use antibiotics according to experience and the surveillance of the etiology of the SU. I need to say antibiotics cannot prevent bloodstream infections caused by ECMO. So it will be a disaster if the infection occurs in the cycling of the ECMO. Maybe we have to remove it or change another set for the patients once the real bloodstream infections in the ECMO. But if the septic shock occurs induced from the ECMO, we need to remove it or change it. That's all.
Thank you. I totally agree with you, and I think to infection control or to prevention of the infection is the first important thing to do for all doctors. And I think for if your patient on ECMO who get hospital-acquired infection, especially some blood stream infection, it's very dangerous. You need to put on the broad antibiotics, and I think there are some issues you need to think about. That's pharmacokinetics and pharmacodynamics, since we all know extracorporeal circulation will have some change to the antibiotics blood concentration. So maybe we need to elevate the dosage of the antibiotics. So that's my opinion. So we will move to another question. Here comes 2 questions. It's all about to confirm the tips of the cannula and to monitor the cannula tips of ECMO. I think this is very important question. We need to ensure or to confirm all the cannula safely and correctly inside the artery or veins. And I think we have several ways to confirm. The first is the clinical condition. That means how is the blood flow in ECMO systems runs. So the blood flow in the ECMO system is the first thing we need to consider. So if you have good enough blood flow in your ECMO system, the cannula must be in the good position. But if you cannot withdraw enough blood flow from the patient, you need to think about, or you need to confirm about the position of the tips of the cannula. And we have a lot of information to combine to confirm the tip of the cannula. That means we need to combine the clinical examination and other image information. For example, we could have some chest x-ray or the x-ray for the abdomen to confirm the tip of the cannula. And for if we use ultrasound at the bedside to confirm or to guide the cannulation of ECMO, we need to separate. There are 2 situations for VV ECMO and for VA ECMO. So for the first situation for VV ECMO, we have one cannula to withdraw blood, and we have one cannula through which the blood goes back. So usually we use the IJC, the internal jugular vein, to send back the blood to the patient. So we need to confirm the tip of the cannula just at the internal jugular vein cross the right antrum. And for most of the situation, it is safe and it is very easy to confirm that. But for the withdrawal blood, we usually use the femoral vein, and we need to put the tip of the cannula. Usually we just put the tip of the cannula at the end of IVC. That's all we know. But for COVID-19 patients, sometimes we need to consider if at the end of the IVC is enough for the COVID-19 patient. Since COVID-19 patient we can see they have the very strong respiratory drive. So they have a big variation of the pleural pressure and also have a big variation of the intra-abdominal pressure. So that will affect the blood flow, the withdrawal of the blood flow from the ECMO cannula. So sometimes for this kind of patient, we just put a little bit deeper of the tip into the right atrium. That's it to say we just put maybe 0.5 to 1.5 centimeter deeper into the right atrium to make sure we have enough blood flow withdrawn from the patient's right atrium. So this is what I can think for confirmation of the cannula in VA ECMO. And for VA ECMO, the withdrawal part is okay with VA ECMO, but we need to consider about the cannula through which the blood goes back. That means we put the cannula in the aorta. And actually, we don't have transthoracic ultrasound to see clearly about the tip of the cannula in the aorta. But we need to consider if the tip is in the right place and if the left ventricle left ventricle's ejection fraction is below 10% or 10% to 20% or over 20%. So that means if the cannula's tip is not in the appropriate position, maybe the blood flow goes back to the left ventricle and we couldn't see the opening of the aortic vein. So that there will be some thrombus in the left ventricle. So that means we need to monitor the opening of aortic vein and to see if we need to adjust the tip of the cannula in the aorta. So that's for VA ECMO. That's all. So any commentary from Dr. Tsai or Professor Chow?
Okay. I think I have a little bit ideas about this. You know, in the VA ECMO, so the cannulation, the tip of the cannula, the most part from the femoral artery, we just inserted into the abdominal artery. So it's the tip is not very high. So if you want to monitor this kind of the position, sometimes we can use ultrasound to see the blood flow. You know, at that time, the direction of the blood flow from the cannula or from the aorta, the direction is inverse. So we can use this as the color Doppler or the other thing to see that first. But not very common we can use that because these kind of patients sometimes under mechanical ventilation, the intestinal function is not very good. So the image, the quality is the times is not very good. So it's not very easy to see it very clear. So from this part, we use this aorta valve to see the the ECMO blood flow. The speed or the flow is enough or not, or we also to see the native cardiac function or the cardiac output is enough or not to make these things keep it in balanced way. So I think this is my ideas about this.
Thank you. So we'll move on.
Okay.
Next section is what can ultrasound see for thrombus caused by ECMO in COVID-19 patients? Which section is generally observed? So please, Professor Chow.
Okay. Actually, I don't have lots of time experience about how to use ultrasound and ECMO to treat these kind of patients. But I think more or less same. This kind of thrombus happens depend on the different conditions. First, the patient's the coagulation function about patients, and the second is it's kind of a foreign body, the cannula or even our artificial lung like that. And also the blood flow inside the cannula, the tubes, and also it's kind of complications. So if we see this is a depending condition, so we just try to figure it into different part. First is venous ECMO. So this kind of ECMO, the most that happen about the thrombus is from some thrombus around the cannula or our tubes. I think this is the first part. So we can use B mode ultrasound to see it directly way to see if it happened. And also sometimes you use a color Doppler to see the blood flow around the cannula, something like that. And also you sometimes maybe this kind of thrombus is flowed to inside our right heart and even inside the pulmonary artery. We will see the high blood pressure resistance of this kind of vascular to see the enlarged right ventricle, something like that. I think this kind of is an indirectly way to see what happened with these complications. And in VA, I mean venous artery ECMO, this part is also something related to the cannula. So just you use ultrasound to see directly from femoral artery or even from axillary artery and from your veins. You can follow your cannula, follow your veins to see it directly. And also, sometimes you use VA ECMO. You use a lot, very strong or very high speed or flow of the artificial machines. From that, you make the aorta valve cannot open, or sometimes the patient's left ventricle, the ejection function is very bad. And that time, sometimes because of this kind of blood flow, the velocity of this is very low. That makes the patients very easy to formate the thrombus. So in this way, we can use our ultrasound, even use TEE, from esophageal echo to see it more clear. So during different phase, different condition, you have to think about the ultrasound to see what happened with this. And sometimes the patients, doctors also use our blood flow like TCD or the other function of the ultrasound to see if there is a very small cloud or bubbles from our artificial lung and our artificial heart machine. So this part during kind of operation duration, sometimes the doctors also use this kind of machine. So I think this is most used way to do or to check this kind of complications. This is my idea.
Thank you. It's very thorough and detailed answer. Thank you. So we move on to the next question. Is ultrasound the most commonly used image modality for cannulation of ECMO? I think this question is for tonight's speaker. So Professor, please.
Okay, thank you. I think the answer, of course, is yes. Although we can also use X-ray to see the cannular's position is right or wrong, but it's not that convenient. Especially in this COVID-19 situation, the protection of the staff must be made when you want to get into the ward. So the technician cannot arrive in time every time. And when we are doing the ECMO, to treat the patient, the blood flow of ECMO, sometimes can get down, reduced because of the cannular's position or cannular's and the aviation relationships moved, or just because of the IVC collapse, the blood flow is down. So ultrasound we can use it as soon as possible. It's just by bed. We can use it in time to find the what's the problem, if the position is not right or just because the IVC collapse, and we can deal it immediately. And except for the VV ECMO and VA ECMO, two cannulars, we also have alveolar islet cannula, which is a double channel catheter. If we use this kind of catheter to do the VV ECMO, we need to put it into the the tip need to be put into the IVC, and it has another hole to get the blood flow back into the right atrium. Must be placed exactly right. And if we use this kind of catheter, we must use TE to guide the catheter insertion. For this for this situation, X-ray is not that good for we see the catheter's position. So echo ultrasound is the best method to see whether the tips of position of the cannula is right or wrong. Yes, thank you.
Yeah. So your answer is yes. Ultrasound is the most commonly used image modality for cannulation ECMO. I think that's all our answers.
Yes.
Okay, thank you. So next question is, what are typical sonographic appearances of lung scans for ECMO-supported patients? I think for ECMO-supported patients, the lung scans or the lung ultrasound wouldn't change because of ECMO supported. So the lung scan of this kind of patient just show the details of the primary infection or the primary consolidation or the primary interstitial syndrome of this kind of patient. So it's viral infection or bacterial infection. So what you have found before ECMO supported and after ECMO supported, it shouldn't be changed, except for you have some treatment for the primary underlying causes. And but we also know that since we have the support of the ECMO for the ventilation, so we need to, or we have to, or we could, to reduce the mechanical ventilation settings to reach ultra protective strategy of the ventilation. So that means the patient could have only a tidal volume only at maybe just 2 ml to 4 ml per kilo predicted body weight. So that means ultra protective ventilation strategy. So with this small ventilation, maybe we could see the pleural sliding is very small. So that's quite different from what you found before the ECMO support, which means the patient might have a strong respiratory drive, and you may find some strong pleural sliding in this kind of patient. And what you have found something new in the ECMO supported patient, it could be due to the mechanical ventilation settings. If you change the mechanical ventilation settings, the supporting level of the mechanical ventilation. And if you keep doing some treatment to your ARDS patient, that means you do some recruitment maneuver, or you do proposition to your patient. So maybe the lung scan of your COVID-19 patient would change. It just correlated to the disease the patient have. So that's my opinion. I don't know what's the opinion from my two colleagues. Do have?
I agree. Very good.
Okay, so we move on. I think we only have 5 minutes left, so we can have 1 or 2 questions. Oh, we only have 1 question left. How often to monitor on ultrasound considering high-risk patient? So I will ask Professor Chow to answer it, please.
Okay, I think it's depend on different conditions. Also depend on the different phases. You know, is initial or the maintenance and withdrawal phases. As the condition is totally different. So you choose your machine, how often or when you use the machine. I think it depends. So my suggestion is you have to have your own local or your own protocol. You know, in this kind of condition, you have the teamwork, work together. You have to figure out who should keep his eye on which part or patients or machines or something. So you have to coordinate the different the teams or team members together. So you have to have your own protocol. I think this is the first priority thing. And if we move into the details, I think during the initial phase, I think the first part is the cannulation insertion. So use ultrasound to maybe pre-cannulation or pre-punct the veins or the arteries. You have to use ultrasound to check if the veins, the vascular is okay for this kind of cannulation. And then you use the ultrasound to get the tips, get your cannulation to the right position. And also, after that, you can make the balance between the ECMO and the native circulation or ventilation functions. And I think this is the most important part. And also, after that, you have to think about your ventilation treatment or ventilator settings, or even as Dr. Zhu Ran mentioned, prone position treatment or the other things. I think she mentioned a lot of details I don't need to talk about. And I think the third part during this condition, the phase, you also have to think about the hemodynamic management. You use ultrasound, you know, during this condition, you not very easy to use, or sometimes people don't want to use a PAC or even PICO because of the fixed principle is not work in this condition. So we only, or what we can believe is ultrasound. So you use this machine to monitor your patient's preload, heart function, even the ratio between the right and left heart. And also you adjust or change your maybe vasoactive drugs or the fluids, and also the blood flow of the ECMO to change a lot of things. So I think the frequency or when you should take your probe to see what happened with your patients is depend on yourself, what you need, what you think. So how worse, how severe about your patients. So if you make sure you understand very deeply or very clear about your patients, I think you don't need to use this machine or use your protocols. But the probes. But if you don't very believe yourself or you can handle your patients, have very strong confidence or very clear, I think you should take your probe to keep your eye on your patients. I think this is my answers. I think after this part of to maybe we move to the maintenance phase or even withdrawal phase, I think the ideas is same. So this is my answer.
Thank you, thank you, thank you. Thank you, Professor Chao. Thank you, Professor Cai. And thank you, Professor Wang Xiaoqing, since he just left for some emergency. And I think here comes a closing moment. And we know we all together have 9 chapters on webinars of management of COVID-19 patients. So please wait and welcome to our next speech. It is on Thursday this week. That means the day after tomorrow. Also the same time from 8:30 p.m. In Asia, and presented by Professor Liu Lixia with the topic of clinical practice with critical ultrasound in COVID-19 patient management, and it is about a series of case presentations. So let's meet again on Thursday night, and good night.
Okay.
Good night. See you.